Hello and welcome to EUFOREA TV Breaking News. My name is Dr. David Bull. I'm a medical journalist and I'm thrilled to be your host for this, our second show of April 2021. This show is all about the comparison of biologicals in CRSwNP care. In a minute, I'll be talking to Professor Wytske Fokkens, Professor at the Department for Otorhinolaryngology at the Academic Medical Centre in Amsterdam. Then I'll be jumping across the pond to talk to Professor Anju Tripathi Peters, who is a professor in the Department of Medicine at Northwestern University Feinberg School of Medicine in Chicago. Chronic rhinosinusitis, or CRS, is a symptomatic chronic inflammatory syndrome of the nose and paranasal sinuses. It affects around 6% to 12% of patients in the Western world, and about 20% of these cases are accounted for by chronic rhinosinusitis with nasal polyps, or CRSwNP. CRSwNP is often difficult to treat, but the advent of new treatments involving monoclonal antibodies or biologics looks like very good news for sufferers. Currently, only two drugs, dupilumab and omalizumab, are licensed for the indication of CRSwNP in the USA and Europe, but others are undergoing clinical trials. Well, to explain all this and to tell us more about treating CRSwNP with biologics, I'm delighted to be joined by Professor Wytske Fokkens. She is Professor at the Department of Otorhinolaryngology at the Academic Medical Centre in Amsterdam and is also Secretary General of the European Rhinological Society and Chairperson of the European Position Paper on Rhinosinusitis and Nasal Polyps, or EPOS. Wytske, it is great to see you. I think it's been 7 months since we last spoke.
Hello, David. It's a real pleasure to talk to you again, and definitely on this very, very important new subject.
Well, as you say, it is a very important subject, and I know that you've been reviewing the existing literature on novel biologicals for CRSwNP. Tell me, what were the challenges you experienced when you were evaluating the existing literature on different biological molecules used in CRSwNP care?
Thank you, David, for this very important question. Let me say that biologicals are really a new way of treating patients that were almost impossible to control in the past, and are really a breakthrough. We're challenged now with a number of biologicals. At the moment there are 2 on the market, but I'm sure others will come. And to define what is the best biological for a particular patient. And we tried to have a look, and the paper has been published in the Rhinology Journal, to what is in the literature at this moment and how these biologicals compare. What is then a difficulty is that the designs of the studies evaluating these biologicals are not exactly the same. The inclusion criteria are not always the same, but also the outcome measures. Some ask for symptoms or measure reduction of smell, for example, but others asked for how many patients who needed surgery when they started to have the trial didn't need surgery afterwards. So it was quite a challenge to try to compare these biologicals and to try to define what would be the best biological for a certain patient.
So tell me then, what are the major differences and similarities between those different biologicals in CRSwNP care? They work in different ways, don't they?
Yes, they work in very different ways. 2 of them, dupilumab and mepolizumab, both block either the receptor or the cytokine itself. And cytokines are ways for the body to communicate in the immune system and can attract eosinophils, the cells that have an important role in the inflammation in polyps and asthma, to the sinuses and the lung. And the third one, anti-IgE, omalizumab, blocks IgE. But we do see differences. All three worked. They all had a significant impact on the quality of life of these patients. They all reduced the nasal polyps, some a little more than others, but none of those differences were significant. They all reduced in these very severe patients that needed another surgery and had severe symptoms and were uncontrolled, improved their quality of life. We do seem to, it seems that dupilumab is more effective, especially on improving the smell in patients with nasal polyps, uncontrolled nasal polyps, than the other two. But it's too early to have an absolute sure notice on that.
I find that the whole concept of sort of personalised medicine and tailored therapy really interesting, and I assume that with these new molecules being used, we're going to see far more of that going forward.
Absolutely. We really hope that this will be an important aspect of personalised medicine. At the moment, we are not very sure what is the best medication for a certain patient. And also in the lower airways for asthma, that is still a question. We try to compare these data in these comparative studies. However, what has not been done is a real head-to-head comparison, and that would be ideal to really predict what is the best treatment for a certain patient. At this moment, now we can choose between dupilumab and omalizumab. We know from omalizumab, it's already on the market for asthma for many years, that is very safe. We don't say that dupilumab is not safe. We just do not have a 10-year experience. On the other hand, we have the impression that dupilumab is more effective, especially for smell, than omalizumab. But at the moment, the differences are too small to give significance.
And finally, perhaps I could ask you, how do you position sinus surgery in relation to using biologicals in CRSwNP?
At this moment, EPOS, European Position Paper, and EUFOREA made regulations or advices when to use biologics. And in these advices, we say that sinus surgery is a prerequisite. And the reason is that sinus surgery is very effective. It's effective in about 85% of the patients, and maybe in polyps a little bit less, and maybe still far over half of the patients.
Well, it's been a great pleasure to talk to you yet again. Thank you very much indeed, Professor Wytske Fokkens.
Thank you very much. It was a pleasure to speak to you.
We're heading to the United States now, to Chicago, where I'm delighted to be joined by Professor Anju Tripathi Peters, who is a professor in the Division of Allergy and Immunology in the Department of Medicine at Northwestern University Feinberg School of Medicine in Chicago. Anju, thank you very much indeed for joining us. I know you have a very busy schedule.
Thank you so much for having me on your program today.
Why did you undertake the initiative to evaluate the literature then, comparing the outcomes of different biologicals for CRSwNP care?
So, as you mentioned, I'm in Chicago at Northwestern University. I'm an allergist. My main research interest and my clinical interest is in taking care of patients with chronic rhinosinusitis. They often have other comorbid conditions. One of the main ones is severe asthma. So I work with these patients, I take care of these patients, I do research on these diseases. And what we know is that especially chronic rhinosinusitis with nasal polyps has significant disease burden. It bothers patients a lot. They don't feel well. It affects their quality of life. And often, like I said, they have asthma, and often their asthma can actually be quite severe. And prior to some of these new biologics that have come on in the market in the US, two of them are approved, omalizumab and dupilumab, and there are two others that have had phase 3 trials that show efficacy and should be approved in the future. our treatment options for these patients were not that great. They got surgery, nasal polyps would often recur, they would get repeated courses of oral corticosteroids, which have a lot of side effects, and even then, their disease wasn't well controlled. What these biologics have done have given us an exciting new treatment option, which do seem to work very well. Obviously, they're not for everyone. And now that we have 2 approved in the US, we have to decide which one to use. They both in phase 3 clinical trials showed benefit. But deciding between the 2 of them is very important. And that's why we undertook this project of comparing these 2 drugs. Again, it's not a head-to-head comparison, and it's what we call an indirect comparison, but it still does inform medical decision-making.
I mean, it sounds like a very exciting time to be in your speciality, the fact that we've got the advent of the biologicals. And I was talking to Professor Wytske Fokkens about this, the fact that we're really seeing very tailored medicine, very personalized medicine now.
Yeah, I think that's the key point. And, we haven't even talked about it, but as we have new developments with new therapeutic options, we know what causes chronic rhinosinusitis with nasal polyps. At least we understand some of it. We know in most people, especially in the Western world, it's what we call type 2 inflammation. These drugs target that type 2 inflammation. So we're doing very much precision medicine, and that is one of the reasons we think that these drugs work, and they really do help patients. Mostly they decrease exacerbations, they improve symptoms, they decrease oral steroid use, and potentially also decrease repeated surgeries or need for surgery. So I do think this is very, very important for our patients.
Well, I think you mentioned earlier that, these are not recommended for all patients. So what would your recommendations then be to care providers dealing with severe uncontrolled CRSwNP before even starting to think about using biologicals themselves?
So you said it. These are patients, biologics you'd consider in severe nasal polyps who are affected, who have disease that's not controlled by what we know are true and well-tried medicines, and are not as expensive and do work, but may not work as well. But in some people, they may be just right. So in general, topical steroids, which either as a nasal spray or different delivery devices or with steroid rinses have shown benefit in nasal polyps. And I do think those should be considered and started in every individual with nasal polyps, barring if there's any contraindication. Most of these patients, I think, deserve at least one small course of oral steroids, and then maybe the topical steroid would work well. If that's enough, I think that's fine. The question if all patients should get one surgery is still unanswered. I do think in patients with severe asthma, as these drugs are also approved for severe asthma and help severe asthma a lot, as well as patients with aspirin-exacerbated respiratory disease, or which in Europe you call NERD, which are individuals with nasal polyps and asthma who have worsening sinus disease, worsening asthma with nonsteroidals like ibuprofen or aspirin. I think those patients, because they tend to have severe disease often recurs after surgery, need multiple courses of oral steroids. I think those patients, you would start a biologic pretty early. The other things you want to make sure, and EUFOREA has done a great job, you want to make sure these individuals have what we call type 2 inflammation, which is what these drugs target. They have nasal polyps and they have large enough nasal polyps. They have significant symptoms. And I think that's how I think of starting these drugs in individuals who have failed topical or nasal steroid or steroid rinses and continue to have symptoms and have large enough polyps. I should make sure about that.
Well, many congratulations on all your hard work. Thank you very much indeed for talking to me, Professor Anju Tripathi Peters.
Thank you very, very much.
Well, that's it for this edition of EUFOREA TV Breaking News. Many thanks indeed to my guests, to Professor Wytske Fokkens and also to Professor Anju Tripathi Peters for their extremely informative interviews on the use of biologicals in the treatment of CRSwNP. You can find more information about EUFOREA and also register for the EUFOREA meetings on the euphorea.eu website, where you can also sign up to receive the latest news via email. You can also follow us on Twitter. The address is @EUFOREA. But that's it for this show. See you soon, and thank you for watching.